Welcome to the HitLab webinar, Preparing for the Surge. Tonight we have with us a phenomenal panel to help us through some of the strategies, digital in orientation, and some of the strategies in medical technology and orientation around the surge and preparing for the surge. With us to start, since he has to run, since he's in the middle of preparing for the surge and actually in the middle of the surge itself in New York City, is the Chief Information Officer of New York Presbyterian. Again, Daniel, thank you for joining us today and tonight, and people listening around the country, around the world. Again, this is a HitLab webinar. We're doing these as a way to get information out to digital health leaders around the world, and we greatly appreciate your time tonight in helping with sharing information about what you're seeing at New York Presbyterian Hospital. Again, for the audience online listening right now, New York Presbyterian is a hospital system located throughout New York City and the New York metropolitan area. It's one of the largest hospitals in the world, the largest private hospital in America, and the largest hospital system in the New York metropolitan area. So Daniel, thank you again for joining.
Well, thank you, Stan. Thank you for having me on. If you don't mind, I'll just give a couple of opening comments about the situation as we find it right now, and share a couple of the insights about what we're doing to react to the situation we have and prepare for what's going to be an even worse situation coming up.
Absolutely.
So, New York Presbyterian has 11 campuses across the New York metro area. We're in Queens, we're in Brooklyn, Manhattan, Westchester. And so we're seeing this on all sides. I think as of yesterday, there were roughly 18,000 COVID positive patients in the New York metro area, and the number is still increasing rapidly. When you are a leader in a health system like this, our CEO and COO have us focused on providing outstanding care. At the same time, we're trying to prepare for everybody who's coming in the door, making a number of decisions about how to use the tests in the best way, how to cohort our patients in ways that are best and most efficient, protect our staff, give the greatest care to patients. We're making sure that we have materials on hand so we can prepare for everything that's coming. We're thinking about novel ways to approach this. This is a novel virus, so we have no experience with it whatsoever. And so we're learning from China, from Italy experiences. And I got to say that the physicians and nurses of our health system are doing a fantastic job responding in every way, delivering outstanding care. And yet the volume of patients is significant. And so it makes us think differently about what we're doing. We're using video technology, remote work, remote access, and remote diagnostics in ways that we had planned on doing, in fact, had underway in many ways. But this is accelerated it tenfold. I'll give you an example. I think that 3 weeks ago, we were doing an average of 100 to 150 video visits a day. Now we're doing well over 2,000. We've ramped up from about 1% of all of our patient interactions being via video. Now we're at 25% or greater. We're making sure that we're serving our patients, those that are not COVID positive, by going to them in their homes using video. We're also trying to keep patients out of our hospital to keep everybody safe. So it's a challenging environment, but it's through a lot of coordination, rapid adoption of technology, and the flexibility of our clinical and operational leaders that we're getting it done.
Thanks, Daniel. And in terms of the preparations that you're making now, you're in the middle of a surge. What are some of the things that you never thought you'd have to do that you're doing today in order to meet the capacity demands that you're seeing hit your hospital, both from a digital and from other types of medical technology? So obviously telemedicine, triaging with online visits, ventilators, other medical technology as well. How are you planning this? The audience right now tonight is really focused around preparing for the surge. What are some of the key recommendations that you'd make to hospital executives around the country that are getting ready to meet the demand and meet the capacity that you're currently facing?
Well, first of all, I'd say I think our government leaders are doing a good job in thinking about how to lessen the impact and flatten the curve by keeping people safer out of the hospitals and trying to increase social distancing. So the more we can do that, the better we're going to be off, and it's not going to get to the second, third, fourth tier cities as it moves west and south. So I hope that no other cities have the impact that Seattle, that area, New York, and Los Angeles have had already. Internally here, what we're doing is thinking about novel ways to treat patients. And I'll give you two examples. Right now, we have the clinical leaders of Columbia University Medical Center and Columbia doctors working together to put patients on dual split vents. And so ventilators are a limiting factor in a virus like this, which has significant respiratory impact. And so to avoid the point of getting to a point where we don't have enough ventilators, we have to maximize those that we do. And one of the novel ways of doing so is finding patients that are roughly similar from a clinical perspective and literally from a physiology perspective, height, weight, body mass, volume of breathing, and then aligning them and putting them on a ventilator together. The ventilator can more than handle it. It's a question of managing the setting so it meets both of their needs. And so that we just started that a couple of days ago. We've had some success already. Our clinical leaders are sharing that information about what we're learning with other leaders around the city and around the country. So split vents is one area. Another area I'm really proud of is the way that we've turned our ORs into ICUs. So we made the decision about a week ago to stop all elective procedures. So we're doing very, very few surgeries. Certainly trauma and life-saving surgery that has to happen, we continue to do that. But we've decreased by a significant percentage the number of surgeries that we're doing. So we have entire ORs that are empty. Starting at Columbia University Medical Center, moving to Weill Cornell Medical Center, at Lower Manhattan Hospital, the Allen Hospital, and New York Presbyterian Lawrence Hospital. We're taking our ORs and converting them into ICUs. So anywhere from 2 to 4 beds in a OR is becoming an ICU. We're moving the beds in where there was just one table for patients before. We'll put 4 beds. We're connecting gases. We're splitting gases. We're moving physiological monitoring equipment in. We're moving extra ventilators in. We're connecting them with their technology. Many of you who work in electronic medical records might be fascinated that we're creating temporary beds in the EMR so that there's a place to admit the patients so that they're in temporary bed 309 and that we can place orders and get results on them. So turning ORs into ICUs is something that I never thought would see happen. And yet we've created probably more than 50 or 60 bed capacity just in the past couple of days doing so, and we'll keep doing even more of it.
And in terms of the work that you're doing with digital and triage, what kind of systems did you set up that are triaging patients through telemedicine, and how long does that take to set up to meet the capacity that you talked about earlier for folks that might be in the Midwest or the Southeast who haven't set up telemedicine yet? If they have 2 to 3 weeks to do this, is it too late, or is there a way for them to set something up immediately, short term, so that they can actually meet that demand before it hits?
Well, great question. First of all, I'd say it's never too late. I'm amazed when there is a crisis at hand, what you can get done. We have great ideas at 3:30 in the afternoon that get developed and implemented by 11 o'clock at night. So we're working at that speed right now. Our digital transformation has accelerated 6, 9, 12 months in just the past 2 weeks based on what we're doing. There is the need for a foundation. You can't create this stuff out of thin air. And I'll give you an example on the triaging. We were already doing a lot of digital medicine. We were doing on the order of about 500,000 video patient encounters every year, even before this crisis hit. And not every one of those was Dr. Smith in his office with Mrs. Jones at home and having that video interaction. That was certainly some of it. But a lot of our video interactions were a pharmacist sitting in the pharmacy doing the med rec for a patient up on the floor via video, or medical screening exams. And this is the example that I'll use to talk about triage. We were having physicians who were sitting in an office somewhere actually seeing many patients coming through our emergency departments and having the interaction with the patient via video, doing a quick medical screening, deciding what needed to happen next and sending them on. I'll tell you a quick story. Our son was 19 years old last summer, and outside of our apartment on the street, he tripped and hit his head on the sidewalk, had a big gash in his side. We got him in a taxi, sped over to the local New York Presbyterian Weill Cornell Medical Center, went into the ED, and he was being seen by a nurse in the little triage area, and she was asking him some questions, and there was a voice coming from somewhere else. The nurse was saying, okay, I'm seeing a 19-year-old male, this is a condition, I'm gonna need this medicine for pain, I'm gonna need this medicine for antibiotics. And I turned around and there was a screen on the wall, and it was the physician doing the medical screening exam. And I thought, oh yeah, I forgot about that. That's something we put into place. So we already had that into place. So what we've done in the past couple of weeks is just ramp that up. So we have entire teams of physicians who are either in one of our clinical operations centers, or, to be very frank, some of our physicians who might be COVID positive themselves, who are out of an abundance of caution keeping themselves home, who are doing video visits, both for patients inpatient and having home visits with patients through video.
That's fantastic. Some of the things that we're seeing around the country right now are issues with regulatory authorities to get some of these digital visits covered, to get some of these new types of pathways approved, particularly in some states where they just didn't have any telemedicine approved and coded and paid for. And I think that's been a frustration for a lot of people. Obviously, New York State, you guys were already set up, New York Presbyterian, New York State, you were doing telemedicine visits prior. I know in talking to Dr. Peter Fleischert, Peter had talked at great length about the telemedicine capacity, really ramping up over the last 4 years, and last year doing over 500,000 remote visits. But what kind of, even with all of that being done with the state, what kind of issues, what kind of policy and kind of regulatory rigmarole would you say that hospital executives, health system executives need to prepare for, to work with state and local leaders to make sure there's reimbursement? Because otherwise hospitals go out of business. What do they have to do to prepare for that side of things?
Thanks for asking, Stan. Well, let me set the table by saying that we run a virtual urgent care business where anybody can go to our NYP app or nyp.org and log in and have a video visit with a physician. So if you're home and you think you might have a urinary tract infection, or you have a headache, or something's not critical, but you want to go to the emergency room, you can have the video visit. We've had that experience for about 2 years. Our physicians were licensed to do this in Florida, in New Jersey, in Connecticut, and New York. And it was all about state licensure that each one of these physicians needed to get. This crisis has dropped all of the walls to the ability to do video medicine, in the ways that there are no longer any state regulations about the ability to practice telemedicine across state lines. I think most of the restrictions about what type of technology you can use from a pure HIPAA and security point of view, those restrictions have been relaxed as well. Not that we want to put anybody's personal information or security at risk, but I appreciate that I think it was the federal government allowed any way that physicians communicate with their patients, even relatively insecure ways like video chat, FaceTiming, and other ways are now on the table to get us through this crisis. The real question will be what we reenact or put back into place after this. I think we'll be in a whole different world where the expectation will be, gosh, you know, during the COVID crisis, we were able to do all of these things via video. Why would we go back to insisting that for the 2-week follow-up after say a liver replacement, why would you need to go into your physician practice? Why couldn't you just have that video visit from home? So I think that what's less interesting than all of the emergency legislation that's been enacted, what will be more interesting is what world we go back to when this is over.
That's fantastic. I know you have to run. Are there any last words of advice that you would give hospital executives that are watching you now or watching this on demand later to prepare for this kind of surge relative to the medical technology, the information infrastructure that you've seen, and even a part of the executive meetings you've been a part of?
Well, it's my fervent hope that New York bears the brunt of it, and that as a nation, we have much less impact elsewhere. But this is less of a technical or a hospital-based approach, and more what you all probably have been reading in the popular press, which is if you think you're overreacting, you're probably reacting appropriately. So there is no amount of overreacting that's possible. There's no amount of over preparation that's possible. Things that we put in place 2 weeks ago, thinking that it was out of an abundance of caution, we used up several days ago, and we're on to the next tier of things that we're doing. So I think preparing in every way, from the supply, from the staffing, from the space, from a process and procedure and readiness point of view, that's all great. And the last thing I would leave you with, particularly for any geographically dispersed institution, have a good virtual command center structure set up. It's one thing I'm proud of that we've done. At each one of our 11 campuses, we have a command center which is manned and staffed by people, but we connect via a virtual command center. So we have a standing WebEx 24 hours a day. It is the source of information. It is the source where we meet, have our daily huddles and updates. And having that in place early on allowed us to communicate well and has served us well when things have gotten even trickier.
Again, thank you, Daniel, very much. And again, coming in from New York Presbyterian at the center of the epicenter within New York City, the Chief Information Officer from New York Presbyterian, thank you very much.
Thanks for having me, Stan.
All right, so we're going to go and just walk through some introductions to the other two participants in the panel tonight about preparing for the surge. First is Dr. John Cohen. He is the Chief Executive Officer of BioReference Laboratory. And that is, for those of you who don't know about BioReference, they are the third largest laboratory in America, over $1 billion a year in turnover. And they are right now, the primary laboratory for meeting most of the testing demand that's happening, particularly in the New York metropolitan area, but around the country. And then also with us is Dr. Marco Koster, who's the president of the University Hospitals Western Region Hospital System, and is going to, again, that's based out of Ohio in the Cleveland metropolitan area, and he's going to be providing really the kind of the background on what they're doing to prepare for the surge. And really my hope is that he and Dr. Cohen both have an exchange about how to prepare not just the general hospital operations, but also around the specific laboratory surge that we're anticipating coming down the pipeline. And with that, let's just go straight to Dr. Cohen with BioReference Labs and just get a lay of the land, Dr. Cohen, on what you're seeing and the capacity build that you've seen over the last month. You and I talked about a month ago when this was just beginning to hit the area, and you were actually meeting in the White House with Vice President Pence and others about getting ready for this and what you would need to get ready. Let's go back to that conversation and what some of the key issues that were brought up when BioReference was being brought into Washington, and you were trying to really alert people about what you needed to build capacity here.
Well, thanks, Stan, for the opportunity to speak. There's been, 4 weeks or wherever is obviously a lifetime ago right now, as this literally is changing still more than every day, I would say almost every several hours. Just to give you a high level, so we became clear that when the CDC launched their, quote, assay and actually published the sequence for the virus, a bunch of people began to look at it, but it wasn't until they actually released they gave the permission for commercial laboratories to begin to develop tests around their recipe that things began to move. It was also clear very early on, that was around the weekend of February 29th, it was also clear that for anybody who was going to bring up the CDC assay, that it was relatively slow. It was manual. What that means is when you get the virus off of a swab, you have to extract it, which is a very manual process for the CDC assay. You plate it, and then you put it onto you extract it, and then you put it onto another analyzer. The other problem was it only runs 40 to 60 tests at a time. So at most, if you're running 24/7, you can run about 100 to 150 of the CDC. That was obviously not going to be a solution. We at the time made the decision to bring up multiple assays at the same time on different, I'll call them platforms, think of them as analyzers or machines, So we had multiple different analyzers because we're a commercial lab. So we were able to bring up, it's called the Roche and Hologic and Seegene and Thermo, et cetera, all at the same time as those vendors began to provide their quote recipes for how to do the testing. So as we moved through bringing them up, we began to get to a higher number of throughput. We started off with a couple thousand, we moved to 5,000, we moved to 10. And as of today, we're upwards of 20,000 tests a day. There are very few commercial labs in the country. We're actually only one of 3 now who are designated by the whoever, task force, whatever, for a variety of reasons, to receive certain supplies through the vendor affiliates. And what that means, so it's Quest and LabCorp and us, and we're all at pretty much, from what I could tell, the same capacity. The problem has been the laboratories in the research laboratories, the health system laboratories, and the state laboratories don't have the ability to scale like we do. So they don't have the logistics network to receive specimens, and they usually don't have the reporting mechanism to send results back. So that was a huge issue for the lab and continues to be for the last couple of weeks as we've ramped up. There has been, I'll go too long, there's also been a supply chain, and anybody who's in the hospital side of this crisis right now knows that there's a huge issue on the supply side relative to swabs, to be able to actually swab patients and get those tests done and then bring them to one of the labs, either their hospital lab or to us. That's been one of the biggest struggles that has occurred. The government has been involved in the supply chain relative to swabs, and I do believe that within the next week, I think it'll begin to break open. But that's the brief story of where we are. In terms of what we're testing now, I like to tell people we're 3 groups. One, we are prioritizing testing relative to hospital inpatients so that the physicians, nurses, medical staff on the front lines can get results as soon as possible. Our turnaround time is basically 24 to 48 hours. For in-hospital ICU, it's about 12 to 24. That's one group. The second group is people who are symptomatic, who are going to their wherever, doctors, ERs, wherever, and sending and are then they're being swabbed, and those types of test kits are then sent to us. The third way of accessing the system right now has been these drive-throughs, which we can talk about if you want, but the drive-throughs have been very successful. Started in Korea first, then in Washington State, and then we actually were the first ones to set it up on the East Coast in the partnership with New York State. So we're running 20 plus drive-throughs now around the country. So if you look at how you access COVID testing right now is basically through your physician or medical group, possibly. Second, through drive-throughs, and third, through hospital criticals. So I'll stop there, and if you want, Stan, do more questions, but that's the current state of where we were 4 weeks ago to where we are today. I will say the need and the demand is enormous. The number of people that are calling and trying to get testing done continues to be insatiable, almost.
So what I'd like to do, Dr. Cohen, I've got Dr. Koster also on the panel here, heading up a major health system in Ohio. And part of what I'd like you to do is tell him, from a laboratory testing standpoint, what does he need to do to prepare his health system, all of his patients, his clinical staff, his lab staff, relative to laboratory operations, which obviously you're one of the world experts on that, but what would you recommend he focus on over the next 3 to 5 weeks while they get ready for the surge in Ohio?
Right, so and I apologize, I don't know how big the health system is and how many hospitals. I will tell you that the greatest difficulty that the hospital and health systems are facing is the lack of appropriate planning to bring up enough testing or some testing enough to get them through the crisis. So what I mean by that is the classic hospital system may or may not be able to bring up the CDC assay. They may have 1 or 2 of the other platforms I talked about. The test needs to be validated. And so it takes time. So I literally probably spoken to 5 hospital system executives today alone who are really behind the 8 ball. I mean, so they're trying to get their testing up. The reason we're talking to them is they're they're reaching out to see if we could do their criticals and their ICU patients as they begin to address it. But even a hospital system, a health system, large system, is only going to do, and most of them will only do a couple of hundred a day. And if you're a large health system, you're going to need to do 500 to 1,000 a day if this hits your city. And that's been the problem.
Okay. And go into some detail. I talked to the CIO of New York Presbyterian just before you joined as well. And he was talking about some of the regulatory and some of the reimbursement hurdles that have to be crossed in order to make all of these connections and actually operationalize fully and scale. From a laboratory medical technology standpoint, what does Dr. Koster, what do health system and hospital executives have to do around the country to work with their local and state leaders to ensure that all of this is going to get covered? Because hospitals were already trending right near profitability before all of this, and this could potentially wipe them out depending on how much they're going to get paid for. What do you recommend they do, and what are some of the blockages that they should focus on with those local and state leaders immediately to plan for this?
Okay, so on the reimbursement side is actually, there's a Medicare rate. We're not paying much attention to it, quite honestly, right now, because we're essentially internally focused to look at, how much testing we can do and what we can bring up and how do we deal with, all of our partners. So that's the reimbursement side of it. The investments that we're making, we are making some very significant investments in reagents, supplies, platforms. We are actually redeploying current personnel because there has been some drop in routine testing, as you can imagine, as most patients are, a significant number of people are not going to the doctor, and if they're not going to the doctor, they're not getting lab tests ordered. So we're seeing a decrease in some of our volumes. What we're doing is we're shifting people over from the type of testing to the COVID-19 testing, essentially reallocating. So that's where we are. We just continue to invest and spend what we need to do to just to get us to where we are. We're going to figure it out, later. We don't, know that we're going to. I don't predict we're going to have a cash flow problem, but we have to see how long this lasts and what other investments we need to make.
That's fantastic. Well, thank you for providing that. What I want to do is move over to Dr. Koster for a minute. And Dr. Koster, just give us a little bit of background on your health system. What I plan on doing is asking you to talk about what you're doing first within your hospital system to prepare. And then and after you give a profile about your health system, and then have you and Dr. Cohen actually go back and forth in terms of having him almost directly talk to you and provide feedback on your preparation. Does that sound good?
Sounds terrific.
All right, fantastic. So give the audience a little bit of idea of what the size and the nature of your health system.
Yeah, good evening. Thank you for allowing us to participate in this exchange of knowledge. We have a very large health system with 12 acute hospitals and rehab hospitals affiliated with an academic integrated health system across Northeast Ohio. We serve more than 1 million lives, and we have a traditional academic ACO models that most organizations have that's very established. More than 500,000 lives are covering our population health initiatives. We do have population digital health, home health, many of those basic infrastructures that exist in large health systems are available and are a part of what we are leveraging today to prepare for the surge of the COVID patients. In our health system in Ohio has had the privilege to have a government that's proactive, that has been a close partner with our health system and our officials. We have created, as most health systems have created, the incident command structure is a FEMA structure that comes to organize, as you heard from Dan in prior, about the use of the command center as your common area through the digital space to communicate and share and deploy inventory. So that's where we have focused most of our time and attention we divided this process into 3 phases. And the first phase, first and foremost, our priority was to protect and take care of our patients and our employees. So we spent a lot of early days trying to figure out what's the best way we could take care of all the humans that touch our health system and those in our community. And in parallel, the command center structure was set up, and then the priorities were to inventory people, inventory skills for the future, inventory supplies. Probably the biggest challenge we have faced, and we have heard before, is related to supplies, lab tests. Just to comment on our health system capability, if you think that just February, we didn't have this crisis, and in March 13, we were allowed as a health system to start providing those based on CDC kits. Today at university hospitals, we have done more than 2,000 in-house tests. That is actually our priority testing for the most needed and the sick patients. We send out to reference labs what is less priority because we need in terms of hours of turnaround. So we are today at 180 tests per day. We are ramping up very quickly. Probably in the next few days, we're going to be at 400. For our health system, we are providing those results in the next 24 hours, but we are coming to 3 9-hour turnaround on average for our patients and for all the individuals that are being symptomatic and are in the hospital. So that's the current state. We are in the state 1, what we call conventional state of readiness, and we continue to move. Yes, in that image there, you show some of our continuum of preparedness. So we are lucky to be a little bit remote from the hot zones, and we have this opportunity to prepare for both the conventional, the contingency, and the crisis that we must be ready. We are counting for 3 times normal volume, meaning 300% capacity, and we are leveraging our health system and our assets across the system to make sure that we are ready in case we face a surge in Ohio and in Cleveland.
That's fantastic. And Dr. Koster, what I'd like to do is ask you to go through the University Hospital's COVID-19 response plan that you sent over to us earlier today. Walk us through that a little bit, and then Dr. Cohen, it'd be great if you could provide feedback on that and any kind of advice and recommendations based on the fact that you've been in the heart of this now in the New York metropolitan area for the last 6 weeks or so, building operations, interfacing with hospital executives all over the country. But Dr. Koster, please go ahead.
Yes, I think I would like just to mention that while we focus on readiness for addressing the problem of COVID, one area that it's very important for us healthcare executives is how we conduct our normal business and how we serve our community who are continue to have chronic diseases and continue to need the support of the healthcare. So that's that initial phase of conventional tier 1 response. As I mentioned, we think about inventory of people, space, equipment, and the importance of the command center structure is that now can be put together in a 24-hour dashboard. So we know in a large health system like ours where to displace and to dispatch inventory or dispatch people when a potential surge or increase in number of beds and utilization is detected. So we create thresholds so as we can achieve a level of readiness. Then we go through, we have the incident command structure that's already functioning over the past 2 weeks. Every day we advance, it gets more aligned and coordinated. And then we have a day-to-day business that we have to manage as healthcare. So one area that probably most 90% of healthcare system across the country is facing is how do you flex and how you control your expenses. We have large fixed expenses in health systems that given the delineation of not to perform what we call essential cases. So that's a new language that we use in healthcare. In the past, we consider elective, urgent, and emergent cases. And today we are discussing more about what is essential and what is non-essential. And when we design your health system, we design to provide care for all individuals. Now we are providing care for essentials. We need to think about how we consolidate and organize our infrastructure to respond to that lower demand. When we reach the tier 2 level, which we are not there yet in Ohio, we are preparing ourselves to be ready. We have 12 hospital system. We have the ability here because we have an integrated intensive care unit, and we have an integrated ECMO system that we have already prepared in the phase 1 to answer the demand that might surge in specific locations. As you know, in New York, there are specific hotspots within that region that might be a bigger challenge for us because we cover more than 92 miles of geographical area. So we have to prepare in a way that we can attack immediately with our teams. So we're creating teams that can be rapid response teams that can go to those places and release the local teams over the next 4 to 24 hours to make sure that we provide that surge capacity for tier 2 level, which is what we're doing right now. And tier 3 level is when the crisis really hits, and then a lot of this rapid response discharge will be all over the health system. We are preparing our teams to do that. We have those plans already for each hospital as well as for the health system, at this moment.
That's fantastic. Dr. Cohen, based on what you just heard from Dr. Koster, are there any pieces of advice that you can give him based on what you've seen in the New York metropolitan area over the last 6 to 8 weeks?
Yeah, I think one of the biggest unaddressed questions, which is coming up fast and furious for the last several days, is addressing the issue of how is he going to screen or make a decision about screening his frontline workers. I only raise it because there's no answer. People are just beginning to try and figure out what are they going to do. It's not just fire, police, EMT, but it's physicians, nurses, and the others. So the issue of not only just should you screen them, it's probably yes, but the question is then when do you screen them again? That's a huge emerging issue for the hospital systems who are right in the middle of this. I don't have an answer for you, but I'm telling you that people need to think about it. I will tell you, I'm actually familiar with your health system, and you are very unusual because I've actually been there. I visited. I've been to the lab. You are an outlier in terms of you have a great lab. I remember it distinctly now. It's all coming back to me. And you have a very sophisticated laboratory system. You are unusual compared to most others, I will tell you. So for whoever's listening, what you've done is definitely on the other side of the curve as to what most people have done or can do. I just don't want people to listen to you and think that this is pretty easy to do. That's all. That's my warning shot to everybody. If they're not thinking about how their lab is going to bring up testing, I mean, I was honestly on with 3 health systems today who still have not validated the CDC assay. It's unbelievable what's going on right now.
So, Dr. Cohen, based on what you've seen, Dr. Costa mentioned that he's at a run rate right now about 180 to 200 a day, and he's got about 1 million members, 1 million patients that he's serving. What amount of volume does he need to get to about a month from now, based on what you're seeing with New York City hospitals with the same kind of patient load for testing capacity for his lab?
That's exactly right. So New York City, we're doing the testing for New York Health and Hospital Corporation, the largest public health system in the country, which is 11 hospitals and 70 outpatient sites. I will tell you that they're going to be at a run rate sometime very soon of somewhere in the order of 2,000 patients, 2,000 tests. They're going to need 2,000 tests a day. And the reason is it's not just their inpatients, but there are a lot of patients still showing up at their emergency rooms and urgent care type facilities. So, if you're 11 hospitals and you really end up in the center, one of these hotspots, 500 a day is not going to make it for you right now.
Okay, well that's good to know. And Dr. Cohen, if there was 1 or 2 pieces of information that you could have known 2 months ago or a month ago before this all started and started hitting you, what would you have done differently to prepare for this?
I probably would have moved to somewhere in the Caribbean. What would I have done differently if I would have known? you know, it's a tough question to answer because we did what we think we needed to do relative to what was coming up on the CDC first published the assay. So it's more of an issue, I'm not going to get into what the CDC or the government should have done, but we got up and running pretty quickly once we had the information that we needed. Remember, a lot of the issues were the vendors who had to make their platforms, their recipes for their platforms for us to bring them up. So I don't know, maybe I can't answer as to what I would have actually had to be better prepared. So that's where we are. We were ready to go relatively quickly once we had the information that we needed.
That's fantastic. And Dr. Koster, one of obviously a big part of what we do is around digital health and medical technology. What kind of digital connectivity do you have set up right now with your lab systems for people to be able to access their test results on a portal, or to be able to connect the labs into an electronic health record system? How is that set up today? And also, for those of you who are watching and listening, please do feel free to enter in questions. We're moving now into the Q&A session of the town hall, so feel free to ask any questions on the panelist Q&A box located on your side of your screen. But Dr. Koster, describe a little bit about the digital integration and the digital work that your team is doing to prepare within the hospital's contingency plans.
Let me just, for one second, answer the question that was posed about screening at hospitals. What we do here, we have consolidated our entrance for our hospitals, which are usually very open in most health systems. So we have tried to design a traffic that preserves physical distancing, but yet allow us to screen with temperature and regular questionnaire. The biggest limitation that exists today from appropriate screening, I think, in America is test availability. And it's not just the assay or the PCR testing, but also the supply chain of the basic components to do the test. Swab was a good example, was mentioned. So if you think about South Korea, 4,000 individuals for 1 million people. In the United States, we're at 5 tests per 1 million. So it's a magnitude that we need to scale very quickly on that testing, so as we can do better screening that's more sophisticated than just measure symptoms and temperature. But to your question, on the digital, I would like to call it, we went 5 years in 2 weeks in terms of regulatory. So we created in 2 weeks a market that probably was constrained to almost to the extreme that was not able to flourish, which was digital health and telehealth, was unleashed by regulatory burdens that were decreased, the borders of states that were liberated, and by reimbursement that now exists and allowing providers to deliver care to much needed patients that can't have physical contact. So in our organization, we leveraged that opportunity very quickly. And there are 2 components to this. One is the regular business and access to our community, which is very important to us, and how we provide access to those patients that are primarily at risk of contact, but they don't have an essential need to come to a hospital. We are taking care of them using all the different platforms. The first hurdle that you'll find in your health system, if you're not prepared yet, is licensing. Licensing not for the medical license itself, but your current provider of digital health may have very old strict criteria for allowing accounts to be created. That does not offer you the speed that you need to ramp up your digital health abilities. So therefore, we are leveraging all the different technology, including Zoom, which we are using today, which is now allowed by the government. So the state of Ohio and federal government have offered us that opportunity. From the back side, which is what's very important for healthcare executives, is how do we monitor this? How do we create transactions that are reliable? And that transaction we are processing this through our normal channels, which in our case, we use TouchWorks and Sorian. So we continue to schedule the patients and we continue to process those encounters through the normal channels that we use in a conventional state. But we are offering the access for patients for the digital interaction, both by telephone, for those who don't have access to video conferencing, and also all different platforms that any provider or any patient can get their hands on as far as we document. So we are creating that new marketplace where we have now reimbursement, we have access to technology, and our patients have access to care.
That's great. And Dr. Cohen, we're getting a lot of questions from the audience about next generation testing. You're at the front lines of this. You're one of the national leaders in testing, if not the national leader in testing right now from the laboratory side. What are you seeing as a next generation test that you think could be out within the next month or so that could be massively distributed and diffused across the U.S. healthcare system within the next month or two?
I would say that the next big leap will be a serology test, which will test for whether or not patients have antibodies to the disease. That will change. That'll change the paradigm sometime a month or 2 months down the road, because it's essentially a plasma-based blood draw where you can determine whether a patient is immune or not based on their IgG levels. It's a very different. Just to remind everybody, the COVID-19 test, essentially what it does is a PCR test. It tells you whether or not you have an active viral infection. A serological test is very different. It tells you whether or not you've had the disease and essentially probably have enough antibodies that you're immune. So that's a big change that will occur. We think will occur in the next month to two, but it's not available right now. That's the big issue going forward.
That's a huge issue. And when do you think that would be available in mass production, mass distribution?
I can't tell you. I mean, I don't know the answer. I mean, there's a lot of people looking at it, so I just don't know. I think it'll be at least a month. It could be longer. But I'm in contact with every single one of these manufacturers now, but I just can't put a date on it.
And do you have any idea when we might be, or if this could ever even happen with this type of virus, a test that would be like a rapid strep test where someone could have a 80 or 90% probability or accurate test on the spot with a swab and a simple solution or test?
So there are some other countries. There are some people pointing to some we call point of care devices. Everybody may have said that they made a big deal about it. Cepheid is a company that made an announcement that they can now do essentially a point of care in a little box. It runs about 6 specimens at a time. It should be at least better for the ICUs or ERs, but it's not made for large-scale testing. So any of these devices, point of care, so far are not going to be able to scale enough to test millions of people currently. That's the problem. So I don't see that yet on the horizon.
That sounds like a lot of what we've been reading and seeing on this as well at our lab. We've got a question from Robin Prasad, and this might be a good one for you, Dr. Koster. Obviously, artificial intelligence, machine learning is a big part of this type of generation of digital health technologies. And again, Robin Prasad is one of the principals at a group called Bold Brain Ventures that do a lot of investments in smart radiology and artificial intelligence-driven radiology. Do you see any of that type of technology coming to the forefront here with what you're implementing or what you're about to implement?
Well, I don't know if the implementation of some of those more sophisticated algorithms in health systems that do not have the infrastructure and the skills would be fast enough. Some of the radiological findings, that might be a very important aspect that I want to touch here about testing, which relates to the false negatives or the negative tests. This is when patients have clear critical syndrome that appears like COVID, but the tests are negative. So this is very common, more common in Europe, in Germany. It's been hypothesized that the virus moves down to the lower airways as opposed to the upper airways where we can collect the swabs. And in that case, I think artificial intelligence using the ability to look at the radiographic changes and be more precise and decrease the inter-individual variability probably could enhance our ability to really diagnose. In the hospital, as we treat these patients in intensive care, there is enormous emotion, there is enormous disruption of the environment when we have a test that's going to take 2 to 3 days to come back positive or negative. The test comes back negative, the patient is still on a ventilator and has all the characteristics of a positive COVID patient. Those are not frequent, but they are not, they have been more common in Europe today than it's here, but I believe that that's going to be a frequent dilemma. So artificial intelligence could actually play a role in helping us in identify with more precision the radiographic changes in COVID patients. That could be one area of incredible help to us healthcare professionals.
And Dr. Cohen, back to you. And again, from Dr. Prasad from Boldburn Ventures, is that something, do you see AI coming into play with what you're doing on the laboratory testing side?
Not yet, I think is the short answer. It hasn't come across my radar yet, to be honest.
And Dr. Cohen, what do states and what do hospitals have to do relative to knocking some of the regulatory issues out of the way when they're trying to set up either drive-by or a drive-through rather, drive-through testing centers or other highly efficient testing centers? What do you recommend they do, and how do you recommend they approach local, city, state officials?
So the regulatory issues have really been significantly lifted. FDA, CDC, state, you name it. Everybody's really cooperating now. And I would tell you, there's almost no regulatory hurdles compared to the way the world was 5 weeks ago. So, but in terms of briefly on the drive-throughs, we have what I call a standard playbook now, since we're doing more than anybody else in the country. It's a team of a whole bunch of folks, but you need people to briefly, you need security and policing, identify a site, security and policing, which means you need your state or local government to sponsor it. Secondly, you need a medical partner, which is usually has been a health system or a large medical group who's agreed that they're going to do the swabbing. And then the third piece, of course, is you need a lab like us who's actually going to do the testing. The other piece is there's a registration and scheduling piece. So there's a front end telephonic piece that's been implemented by most of these, so that you just don't have people showing up. The problem with the FEMA, at least some of the FEMA sites, most have been that they've been open to everybody, and it's been a disaster. Just people just showing up without appointments, and so it hasn't worked well. Plus the reporting mechanism isn't great. So those are there's a sort of 4 broad pieces that you put in place. So it takes a multidisciplinary approach, like all these things, with all these pieces, with everybody getting in the room. It takes about a week. Right now we're seeing roughly a week to get everybody coordinated to set up a drive-through. So if you're thinking about doing it, start now. But you do need those pieces in place. That's just the learnings that we've had. And as I said, we actually have a playbook on this now to figure out how to get it up and running.
That's great. And Dr. Koster, from the surge side of things within your hospital, do you have any questions for Dr. Cohen about regulatory and reimbursement issues that you're running into there, and how to either reduce or remove some of the blockages on the regulatory and reimbursement side?
No, I think, as you mentioned, I think the regulatory burden has been lifted. I think there is enormous cooperation between government agencies and even the private healthcare insurers to help us, and we are all coming together. So we're not facing regulatory burdens to prepare and to address this crisis at this moment. But I would like to reemphasize that there is no over preparation. There is no abundance of caution. There is not enough that has been said about this crisis that we are taking very seriously at university hospitals. We are setting up our infrastructure for those in the digital space. Think about your infrastructure. For instance, how many gigabytes per second your network can handle. We went to 5 here very early on to be able to manage all the visual trafficking of information. Think about your digital intensive care units. Make sure that you test those. You have time now to really run mock tabletop incident command planning. And I urge every single health system in the nation to, number one, leverage your digital capabilities. You need incredible support and infrastructure in IT and the ability to connect with your patients. Otherwise, you're going to be shut down from your community. And that's not what you would intend in the middle of the crisis. So there is enough time, and digital and the IT technologies that exist today are available with minimal regulatory burden for you to be prepared for this crisis.
That's fantastic. Dr. Cohen, in terms of some of the financing and some of the reimbursements that you're seeing in the New York metropolitan area, what would you recommend to Dr. Koster about seeking, and who does he talk to at the federal level or at the state level or local level about receiving some kind of financial support while he's going through all of these massive operational upgrades, getting ready for a surge?
Yeah, I'm watching what's going on in in New York and New Jersey epicenters, and it's really the governors. There's some counties who are looking to the state for funding and guidance, but it's really falling on the states to fund downward, including obviously the hospitals and the counties, and then it's the governors reaching upward to the feds to make sure that they get the funding they need out of the bill, out of the reconciliation bill, and I guess the new bill that just passed, to make sure that their state gets what they need, because that's how they're going to pass it down. It looks like right now, or at least I'm not sure about, to get it to the hospital.
Okay, great. And Dr. Cohen, from your perspective, do you think that the post-COVID world will be like the pre-COVID world, or do you think it'll be massively changed because of what we're seeing today? And if it's going to be changed, what do you think will be different in post-COVID America?
Wow, that is an impossible prediction to make. We are focused so much in taking care of the COVID world right now that I didn't spend much time of thinking what's going to be afterwards. What we know is going to be different. We know that our social interactions will be impacted at the personal level and at the professional level. What we know is the respect that we're going to have for diseases and for each other will change. And we as health systems, we have learned how to operate in a much better way. So there are things that are coming from this that's going to be incredibly positive. Our teams, our administrators, our nurses, our staff, our ADs, all of us have come together. We have done a survey just this week about skills, different skills that everybody can contribute. And we have had a massive response and many individuals who offer to serve in any different capacity to help our population. So those responses we have not seen yet before in the United States in a magnitude that we are seeing today. This is not a one-day crisis. It's a long journey. It's going to take a little while for us to even understand what is going to define post-COVID crisis, what is the time frame. And I think what we need to do now is to focus on today, on the moving present, and how can we do the best we can as a society, as individuals, and also in our case as health systems, to make sure we protect our patients and our employees, because we are critical in this phase to address this crisis.
That's fantastic. Well, thank you, Dr. Koster. Thank you, Dr. Cohen, for joining us. Thank you for all of our attendees for joining in as well. And everyone, please stay safe, stay well, and we'll see you next week here at HitLab. Take care.
Take care. Thank you.
Thank you.
you.